This video I'm discussing about SLE, systemic lupus erythematosus. Systemic lupus erythematosus comes on history and also clinical, so management portions. Remember, in SLE features always you can be find the steroid toxicity sign. Steroid toxicity sign, we know that moon phase, there is increased spread of fat of the back and the stria, obese, hirsutism. These are so normally the diagnostic criteria of SLE easy to remember: SOAP, brain, MD. The mnemonic is SOAP. S for serositis, that is pruritus and pericarditis. O for oral ulcer, A for arthritis, P for photosensitivity. SOAP. Brain. B for blood disorders, R for renal involvement, A for ANA positive, I for immunologic, that is NTSM and NT-dsDNA. N for neurologic. Then MD, malar rash and discoid rash. So in SLE history, what we can find? First of all, rash is very important. That is cheek rash. We all know that. Then all the features like chest pain, palpitations, oral in mouth. There is ulcer, arthritis. The child has difficulty in walking. Photosensitivity when go over the sun. The rash is prominent. Then blood disorder. The child is pale. Renal involvement. The child urine color. They can say. Then psychosis can be developed. Then malar rash, discoid rash. So these are the features we can find in the history when we take the SLE history. That is slick classification criteria of SLE. Requirements more than require 4 criteria, at least 1 clinical and 1 laboratory criteria, or biopsy proven lupus nephritis with positive ANA or anti-DNA. Now, clinical criteria and immunologic criteria. Clinical criteria of SLE are number 1, acute cutaneous lupus. Number 2, chronic cutaneous lupus. Number 3, oral or nasal ulcers. Number 4, non-scarring alopecia. Number 5 is arthritis. 6 is serositis. 7 is renal. 8 is neurologic. 9 is hemolytic anemia. 10 is leukopenia. And 11 is thrombocytopenia. That is less than 1 lakh per millimeter cube. Also, some immunologic criteria of SLE. These are number 1, ANA. Number 2, anti-DNA. Number 3, anti-SM. Number 4, anti-phospholipid antibody. Low complement. Number 5, C3, C4, CH50. So, low complement. 6 is direct count test. Do not count in the presence of hemolytic anemia. So, these are the features. How can we manage a SLE patient? So, uh, investigations, what we do? Examination, we do musculoskeletal, all examination, abdomen, musculoskeletal, neurology examination, general examination, skin examinations, everything, mouth examination, GIT. And investigation, what we do? Number 1 is full blood count. In finding full blood count, either normocytic, normochromic anemia of chronic disease, or pancytopenia with leukopenia, and thrombocytopenia or autoimmune hemolytic anemia. So there is pancytopenia we can find, sometimes normochromic normocytic anemia. ESR is high with normal CRP. Urinalysis, liver function test, kidney function test we will do. Then autoantibodies, ENA panel. Autoantibodies, what we find? Number 1, ANA is strongly positive, sensitive but not specific. Then anti-double stranded DNA, that is highly specific, may reflect the disease activity, especially the nephropathy. Then anti-ENA, that is antibodies against the extractable nuclear antigen, not very specific. Then anti-Smith antibody, anti-RO antibody, anti-LA antibody, rheumatic fever, positive in 30%. Anti-RO antibody, SLE plus Sjogren disease. Anti-LA antibody in neonatal lupus. Anti-phospholipid antibody is positive in 30% and increased risk of thrombosis. Anti-histone antibody increase in drug-induced lupus. Anti-RNA antibody associated with Raynaud phenomena, and if high, it is associated with mixed city disease, not SLE only. Anti-RNP is associated with mixed connective tissue disease, and neonatal lupus is almost always caused by anti-RO and anti-L antibody. So, first full blood count, ESR CRP high, then urinalysis, liver function test, then autoantibody. Autoantibody is only name and I am telling: ANA, anti-double stranded DNA, anti-ENA, anti-Smith, anti-RO, anti-LA, anti-phospholipid antibody, anti-histone antibody, anti-RNA antibody, anti-RNP antibody. Number 5 is complement level, C3, C4, hypocomplementemia, often present. Raised complement is against the diagnosis of SLE. So remember, hypocomplementemia. Raised C3, C4 is against diagnosis of SLE. Then imaging, we do the chest X-ray, echo, and cranial MRI, depends on clinical findings. Abdominal ultrasound for hepatosplenomegaly, joint ultrasound, or even joint aspiration if needed after liaison with the interventional radiologist. Then slit lamp for uveitis. Number 7. Number 8 is bedside test, blood pressure, random blood glucose, and urine dipstick. Now, what are the advice I am giving for SLE? Number 1, diet and exercise. Avoid high calorie, high salt food, and avoid steroid-induced weight gain, and encourage exercise. So, diet and exercise, we are avoiding the high calorie food, and doing exercise. Number 2, sun protections, wear sunscreen. And number 3, avoid the nephrotoxic drug. Number 4, education of the family about the side effects of the medications. Number 5, report any chest pain. Ask medical advice immediately. So report any chest pain, that is a red flags. Number 6, fatigue and sleep. Fatigue is common and affect the school performance, and steroids may induce the sleep disturbance. So liaise with the school. Number 7 is psychosocial issue. That is education of the child and the family about the SLE is essential. Poor school attendance may indicate psychosocial issues. Number 8 is immunization. Live vaccine are contraindicated in those on corticosteroid or immunosuppression, but pneumococcal vaccine at diagnosis and 5 yearly and influenza vaccine yearly is recommended. Then number 9, steroid card and bracelet. So these are the advice we are giving SLE patient. Now, how can we manage treatment? What are the medication we give? That is non-medical treatment and the medical treatment. Non-medical treatment is rice. Rice is that rest, then embolizations, cold compression, elevations. Then medical treatment we are giving number 1 NSAID for musculoskeletal symptoms and serositis. So NSAID we are giving. Then number 2 hydroxychloroquine. Hydroxychloroquine is the first line treatment for mild disease like skin or joint pulmonary disease, or as adjunctive treatment in more severe disease. Annual monitoring, visual field, color vision is done. So hydroxychloroquine we give, and we are following up vision field and the color vision. Number 3 is corticosteroid. So corticosteroids are nearly always required at some stage. In severe systemic disease, IV methylprednisolone for 3 days is given initially, followed by oral prednisolone, which is subsequently tapered. Number 4 is immunosuppressive agents. Azathioprine or MMF is used for moderate or severe disease, and cyclophosphamide for severe organ involvements. Number 5, anti-TNF, that's in infliximab or etanercept, not used in SLE as it can induces the low pass activity. Number 6 is for severe disease resistant to standard therapy, that is rituximab, plasmapheresis, splenectomy, autologous or allogenic bone marrow or stem cell transplant. So I am telling only the headline. What are the treatment we are giving? Non-medical treatment rice, medical treatment are NSAID, hydroxychloroquine, number 2, number 3 corticosteroid, number 4 immunosuppressing agent, number 5 anti-TNF. Infliximab, these are not used, remember. Anti-TNF not used. The team I will involve the multidisciplinary team, that is consultant, my consultant pediatrician, physiotherapist, occupational, school orthotist, orthopedics, hand and foot specialist, that is called chiropodist. Then ophthalmologist, nephrologist, cardiologist, pulmonologist, liaise with the school, and psychologist. Note, infection is an important cause of mortality. Causes of chest pain are pleurisy, pericarditis, pulmonary embolism. So this is all about SLE. It comes on history and also clinical examination. Video session never come, but can become as a rash over the cheek. Remember. Thank you very much.